A very good evening to all the teachers, seniors, colleagues, and PG students. At the outset, I would like to thank Dr. Bala Bhaskar sir and the Ballari Anesthesia Society for hosting this wonderful academic session every month. And indeed, it is very important to shape the future of our anesthetists and PG students. So ever since we have entered our branch, we have been dealing and handling the anesthesia machine and equipment, right? And when we were in our PG days, this topic was very difficult to understand, maybe because we were not able to understand its importance actually, right? So coming on to the topic, that is the scenario-based troubleshooting of anesthesia machine. So in this talk, I'll try to review the most common and life-threatening problems that are associated with anesthesia machine and equipments during perioperative period. So to better understand, we should know a little bit about the history also. And as we know, the founder of our modern anesthesia, that is Sir William Thomas Green Morton, he is considered as the father of anesthesia. He first publicly demonstrated on 16th October 1846 in Massachusetts General Hospital, USA, with the help of ether dome or flask inhaler type of anesthesia, and he demonstrated uh, in surgery, right? Anesthesia during a surgery, right? Okay. So later on, we moved to the Schimmel-Busch mask, and till 1950s, we used this. It was an open block ether method and semi-open anesthetic breathing system. But it had also a lot of problems, and we moved on further to the anesthesia machine, right? So why there was a need for anesthesia machine? So what happened in 18th century when a lot of gases which were being invented and introduced, it was in compressed form, and we needed a metal framework to support and blend with volatile and inhalational anesthetic agent. So to safely deliver the precise mixture and anesthetic gases and oxygen, we needed anesthesia machine. So in 1917, British Oxygen Company uh, introduced Boyle's machine, which was first introduced by Sir Henry Edmund Gaskin Boyle, and in the honor of Sir Boyle, this machine was named Boyle's anesthesia machine. And a lot of progress was made in the coming years, like vaporizer was introduced in 1920, in 1933, dry bobbin type flow meter was introduced. In 1937, rotameter was added, and so on, right? Okay, so nowadays we use anesthesia, modern days anesthesia workstation. And I have seen a transition from Boyle's anesthesia machine to anesthesia workstation also. So Boyle's anesthesia machine is basically pneumatic, and anesthesia workstation, which we use, has got a pneumatic as well as electrical and electronic component incorporated in it with integration of ventilator and monitor. Right. So who sets the standards for these anesthesia machine? Because we need to monitor basic uh, there is basic monitoring standard like breathing system pressure, inspired oxygen concentration, vapor concentration, end tidal CO2, blood pressure, ECG, SpO2, the oxygen supply pressure, and alarm system. We all need to know, but how? That is the question. So there are various organizations, right? Like ISO, that is International Organization for Standardization, the American Society for Testing and Materials. They provide manufacturers with guidelines outlining minimum performance design, characteristics, and safety requirements, right? And they ensures patient safety. They promote a reliable performance. They facilitate safe and effective clinical practice. This I think everybody is clear. They have idea about the high pressure system, the intermediate and low pressure system, and at the at various pressures on which they work, like 2000 or 750 psig, it is converted to 45 psig or 50 to 60 psig from the pipeline, and low pressure system 5 to 8 psig above the atmospheric pressure, right? So little bit about the components of anesthesia workstation. Apart from the pneumatic system, we need to know the electrical system and electronic system also, because we have additional master switch, power failure indicator, the electrical outlet, the check mechanism associated with alarms and notification to alert, data communication, digital flow meter, advanced monitoring, anesthetic gas concentration, and ventilator setting also, right? Okay, so we have evolved and we have improved to a sophisticated, integrated, computer-assisted physiologic monitoring and anesthesia delivery system, right? Because we have now agent-specific vaporizers, we have oxygen proportionating system, oxygen analyzers, oxygen failure safety valves, we have breathing circuit pressure monitors, and we have pin index safety system, right? So now the focus of my talk will be to identify the most common life-threatening problems which we deal in our day-to-day anesthesia practice. So there are various causes. We can categorize into four types. Equipment causes of hypoxia, the equipment causes of hypocapnia and hypercapnia, the excessive airway pressure, and the volatile anesthetic agent delivery issues. So basically, we get problems in these four types. So there are various articles which I went through, and everybody stress every article they were stressing uh, on the prior anesthesia machine checkup before giving anesthesia to any patient. Right? So there was also a study which was conducted on Primus Drager anesthesia machine to analyze which are the most common problem they met with, and the leaks were found to be very common with these systems. So you have to identify, and until unless you do a pre-anesthetic machine checkup, you won't be able to identify. Okay, so coming on to the first classification, if I say that equipment causes of hypoxia, you can get at various levels. Like at if you are getting a hypoxia, then you get a hypoxic mixture. That means, right? So the problem can be at source, that is empty oxygen tank or incorrect gas from nitrogen or medical grade oxygen from the source, right? And you can get pipeline issues like misconnection or crossover or closed valves or disconnection of oxygen hose. You can get problems at the flow meter level, like inadvertent lowering, accidental lowering, dirt, grease, or oil, the bobbin, they get stuck, right? There can be misalignment of the Thorpe's tube, or there can be improper calibration or the problems with static electricity. So you can get problem with faulty or absent unidirectional valves also, and you can get leaks also at the different level like flow meter, anesthesia, machine hoses, the canister, the breathing circuits, and the reservoir pad. So you monitor for hypoxia through pulse oximeter, right? But with pulse oximeter, there is a problem. Like it cannot tell you whether it is from equipment or it is patient related. Whereas oxygen analyzer, if you are getting low oxygen level, it will tell you that it is at the machine or equipment related, right? So uh, moreover, with there are also some problems with pulse oximeter, like you can get a false positive with probe malposition or excessive movement, or if there is electrocautery, or if there is skin pigmentation, or if you are using dye like methylene blue or indocyanine green. So in all these conditions, you might get false oxygen reading, right? So you monitored with the help of pulse oximeter and oxygen analyzer. You got the problem and you got the solution. You corrected it, right? But if you are unable to identify the problem, then what you will do? You might have to replace the anesthesia machine along with a reserve full oxygen E-type cylinder at the supply, right? The clinical relevance is like it's dependent on the size of the leak. If the problem cannot be quickly identified, then it's better to replace the machine, right? And the patient can be ventilated with ambu bag also if you don't have the machine, right? And if the oxygen is also finished, then at least you ventilate with ambu bag. And once the patient is settled, it's better to postpone the surgery for that day. So no, now we have to know about the equipment causes of hypercapnia, right? So it can be due to increase in CO2, or it can be due to decrease in elimination of CO2, or it can be due to increase rebreathing of CO2. So there can be number of causes. So the causes for increased CO2 is like if the patient is getting inadequate tidal volume or respirated rate due to failure of velours, right? Or it can be due to kinks or obstruction in expiratory hoses or breathing circuit or endotracheal tube. Now you can get decreased elimination of CO2 with leaks in the machine, breathing circuit, CO2 absorbent or ventilator. And you can also get decreased elimination of CO2 with uh, exhausted CO2 adsorbent or uneven distribution of CO2 adsorbent or deactivation of ethylene indicator, right? So there are also number of causes for increased rebreathing of CO2, like if there is increase in apparatus dead space due to faulty unidirectional valves or increase in the distance between endotracheal tube and the breathing circuit, or rebreathing excessive increase rebreathing with excessive low flow anesthesia if you are giving like है ना, and if there is like inner inspiratory tube, if it's damaged or kinked or avulsed, then also the rebreathing of CO2 can be increased, right? Now the causes of hypocapnia, like inappropriate ventilator setting, you can get some problem with capnograph also. If there is leak or obstruction in the sample, if there is removal of water tap, or if the sample is too much diluted with high fresh gas flow, right? There can be complete airway obstruction also, and there can be leak in the endotracheal tube cuff. So what do? We have to monitor with the help of capnograph. That is mandatory, right? What is the solution? If it is a problem of adsorbents, then replace the adsorbents. You change the unidirectional valve and you increase the fresh gas flow. Even though then also if you are getting unexplained hypoventilation or increased resistance, then you have to go for manual positive pressure ventilation. And if during manual positive pressure ventilation, compliance or breathing resistance is abnormal, then the fault, it lies in anesthesia delivery system. Breathing can be in the breathing circuit or patient. And if it is still difficult to ventilate with a resuscitation bag or a new anesthesia delivery system, you have changed now the delivery system, the problem then definitely lies with the airway device or the patient, right? So you have to keep a backup anesthesia machine with breathing circuit. And then also if the problem is with the patient, then you have to suction it and then you have to re-intubate it with the endotracheal. So now another set of problem is like excessive airway pressure. Then what are the causes? The causes can be due to sticky oxygen flush pump. It can be due to quick oxygen flush in the non-breathing circuit. You can get obstruction at the level of expiratory limb, the ventilator, or the scavenging system. Now, how do you monitor and detect? Through pressure manometer, through ventilator alarm, due to overinflation of reservoir bag also. You can get that there is some resistance. Okay. Prolonged thoracic expansion and capnography. In capnography, what you will see, there is ascending limb with a prolonged rise and there is no plateau. So what is the solution? You immediately disconnect the machine. And you can also use some non-latex bag, which can bear more than 50 millimeters away mercury, because latex reservoir bags, they can maintain pressure up to 50 centimeters of water, right? So you can also inflate endotracheal tube up to 20 centimeter of water, not more than that, because you have to limit so that if the pressure rises, the air can come from the sides of the cuff, right? And you can open the APL valve or pop-off valve. Now, the issues relating to volatile anesthetic agent, what are the problems? It can be due to tipping. It can be due to filling of incorrect anesthetic agent. It can be due to leaks in the vaporizer. It can be due to empty vaporizer, or if you accidentally off position interop or incorrect calibration. And how do you monitor? Gas analyzer through infrared spectrometry. And the solution is always check the vaporizer, fill before every case, and tidal agent monitoring, and pre-use equipment checks like calibration and proper locking of the vaporizers, right? So in a nutshell, the faults which can be remedied are power failure, gas failure, ventilatory failure, the fresh gas delivery failure, gas measurement failure, the screen error, the user interface failure, and the system failure, right? So now, before going to the scenarios, we should know why these critical incidents happen. See, we are working in a closed loop control system where one component is anesthetist, one is patient, and one is anesthetic machine. When one or more component of this loop behave unpredictably, we can meet these critical events. Okay, so to improve this, we have to know the ergonomics, that is the study of efficiency of the person in his working environment, right? For an anesthetist, it is the OT. So human factors engineering like design and development of equipment to improve the ergonomics of a task, right? So why it is developed? To make it less tiring, to make it less stressful, to make it more safety, for more safety, right? So interaction between anesthetist, the anesthesia machine, and patient, this should be in a very cordial, and there should be no stress, right? So apart from all these things, you need to have a good intelligent alarm system, like, and the alarms, like we all have seen in our anesthesia workstation, you can get a warning, you can get a caution, you can get an advisory or technical message, right? So what is a warning? Warning is a statement that provides important information about a potentially hazardous situation. And if it is not corrected, it can lead to catastrophe. So you have to immediately rectify it. The other is caution, and it statement provides important information about a potentially hazardous situation, but if not avoided, it may result in minor to moderate injury to the patient. So you have to correct, but it's not that necessary to correct it at that time only, right? Likewise, you have an advisory and then you have a note also. So you need to have a good intelligent alarm system. So this flowchart tells you by the time you get hypoxia or you get a decrease in SpO2 in your monitor, there are a lot of events that happens, right? Like power failure, oxygen supply failure, nitrous to oxygen ratio, breathing circuit pressure. There are so many things. And if you get alarm at power failure level only, so you will be able to rectify it immediately, right? Okay. So now coming on to the last part, that is I'll be discussing few scenarios with you, and you need to tell me, and it will be very interesting. So the first scenario is like a 55-year-old male patient is undergoing an elective laparoscopic cholecystectomy under general anesthesia. The procedure was going smoothly under controlled ventilation with isoflurane in a mixture of oxygen and nitrous, right? Approximately 40 minutes into the surgery, anesthetist hears a high-pitched alarm from the anesthesia machine. The oxygen pressure gauge shows zero, and the FiO2 drops rapidly on the gas monitor. The patient SpO2 begins to fall from 98% to 90%. So what do you think? What should have happened? Let's see. So what will be your immediate response? You will quickly switch over to manual ventilation and ambu bag. You might have ambu bag also connected to oxygen cylinder, right? Nitrous oxide is turned off. You have a backup oxygen cylinder and that is open. Capnography and pulse oximetry is closely monitored. So what do you think? What might have happened? Disconnection of oxygen pipe, right? Okay, so how did you assess and what should be your troubleshooting? The oxygen pipeline, in this case, the pipeline oxygen hose was inspected and found to be disconnected on the wall outlet. No other gas was affected. After reconnecting the hose, the pipeline pressure was restored, right? So rest of the things came to the track. Again, SpO2 returned to 99% and the event was documented and submitted, right? And what is the key learning from this event? That the machine should be checked daily. The fail-safe system, actually it worked here. The most modern machine will shut off nitrous oxide when oxygen fails. This function, it worked here, right? So monitoring of FiO2 and SpO2 and the crisis management, that has to be very prompt. Okay. Now scenario two. A 30-year-old female was undergoing a breast lumpectomy under general anesthesia. After induction with propofol and fentanyl, she was maintained on sevoflurane with vaporizer set at 2% with 50% of oxygen in air. Muscle relaxation is achieved with rocuronium. Okay. So what was the event? Event was after 15 minutes into the procedure, the patient begins to move slightly and there is sudden increase in heart rate and blood pressure. Capnography and ventilator parameter remain normal, and tidal sevoflurane on the anesthesia monitor reads 0.3%, right? Much lower than expected. What might have been the cause? What did you do then? You gave manual bolus of propofol. That is what we do to deepen the anesthesia. And then the vaporizer was inspected. It was set at 2%, but there was no smell of sevoflurane. And the agent level was critically low. So what do you suspect? Vaporizer malfunction, inadequate anesthetic depth due to vaporizer malfunction, right? So your assessment and troubleshooting, the vaporizer chamber was found empty. Then anesthetist fills the vaporizer with fresh sevoflurane and restart the gas delivery. The end-tidal sevoflurane gradually returned to the normal therapeutic level. So depth was maintained and there was no recall or no recall of awareness, no recall or awareness. Right? So key learning points. Always check the vaporizer before every case. You have to fill it up. And tidal agent monitoring is also very important. This is how you came to know, right? The patient responses, the clinical blood pressure and heart rate, SpO2, movement, these all have to be monitored very closely. And pre-equipment check, that is always very important. So now coming on to the scenario three. Midway through a laparoscopic cholecystectomy, anesthesia machine suddenly triggers a high airway pressure alarm. The ventilator shows a peak pressure of more than 40 centimeter water. The patient's chest movement appears reduced and SpO2 begins to fall. So, what can be the possible causes? Obstructed airway, yes. Kind of blocked endotracheal. Circuit obstruction, water in the circuit or blocked filter, right? Malfunctioning APL valve, yes. Incorrect ventilator setting, tidal volume too low. From the patient end, you can have a bronchospasm also. And you can have reduced lung compliance due to pneumothorax or tension from surgical insufflation, pneumoperitoneum, right? So it's a case of high airway pressure alarm. And what did you do? You switch to manual ventilation to assess the compliance. You check the patient first. You auscultated the lungs, wheezes and breath sounds. You suction the ETT for this any secretion. You inspected the breathing circuit for kings, water taps, or block filters. You checked the ventilator settings. You ruled out any surgical cause. Okay. And you administered bronchodilators from bronchospasm if you had. So in this case, there are lot of safety mechanism in your anesthesia ventilator. So anesthesia machine was well equipped with pressure limit alarms and release valves, which in which the machine indicated and the anesthetist was able to decipher, right? So that is why there was no barotrauma because timely the action was taken and it was intervened on. Okay, so resolution in this case, there was a kinked breathing circuit tube and it was identified and corrected. The pressure was normalized and SpO2 returned to the baseline. Now coming on to the clinical scenario 4. During a prolonged abdominal surgery under general anesthesia using a circle system, the anesthetist notices that the patient's end-tidal CO2 is steadily rising despite maintaining appropriate minute ventilation. Inspired CO2 is more than 2 millimeters of mercury. The patient also developed tachycardia and a slight increase in blood pressure. What might be the possible causes? Exhausted soda line, incorrect installation of absorber canister, bypass of absorber due to faulty valve, yes, and channeling of soda line, right? The gas flows around and not through the absorber. Okay, so it's a case of CO2 absorber exhaustion. So troubleshooting steps: verify the entitled CO2, right? Inspect the soda line, see the color indicator. You feel the temperature because it's an exothermic reaction. You will always feel warm if it is active. Switch to high fresh gas flow, more than 5 liters per minute. Replace the CO2 canister with a fresh one and confirm it with proper sealing and sealing. Okay. So capnography and FICO, entitled CO2 was very important in this case. The resolution was the soda lime canister was exhausted and it was cool to touch. So it was replaced with a high flow oxygen and high flow oxygen was temporarily used. End-tidal CO2 and FiCO2 levels returned to normal and the patient remained stable. So coming on to the scenario 5, shortly after beginning of general anesthesia, the anesthetist notices that the patient's SpO2 is decreasing despite an inspired oxygen concentration FiO2 of 100% on the monitor. The oxygen analyzer shows a low FiO2, that is 21%, and the patient is not responding to increased flow of FiO2. What might be the causes? Okay, so crossed wall outlet or hoses, poor color coding or labeling of gas lines, it can be incorrect, right? Absence of malfunction of pin index or gas specific connectors, um, failure to use oxygen analyzer and check FiO2 pre-induction. Might be, right? Let's see. Okay, in this case, there was a crossed pipeline connection, right? The nitrous oxide pipeline was connected to oxygen inlet and delivering the hypoxic gas despite oxygen flow meter being turned on. So it was a case of incorrect gas pipeline connection. What were the troubleshooting steps? You check the FiO2 monitor, you listen to oxygen failure alarm, the switch immediately to oxygen cylinder supply, you disconnected the pipeline gas supply to prevent further contamination, and you notify the technical staff to rectify it, right? And what were the safety features that were involved in this? One is oxygen analyzer, and one is the fail-safe mechanism. That is nitrous oxide shut off if oxygen pressure falls. Okay, so oxygen supply pressure alarms, it will give you alarm, right? And pin index system. These all are safety systems which were involved in this. So resolution was oxygen pipeline was found to be misconnected with nitrous oxide due to maintenance error. The pipeline was disconnected, the cylinder supply was used, the machine was rechecked thoroughly, the patient was stabilized after switching to the verified oxygen source. Coming on to the scenario 6. During a routine laparoscopy procedure under general anesthesia, the operating room suddenly experiences a complete power cut. So anesthesia machine screen goes black and mechanical ventilation stops. The monitors also lose functions unless battery operated. The surgical field lights dim and the procedure was paused. So causes: a failure in hospital's main power supply affects anesthesia machine and associated equipments. The machine either lacks an internal backup battery or the battery has failed due to lack of maintenance. So it was a case of power failure. Immediate action was to switch to the manual ventilation, right, with reservoir bag or APL valve, an APL valve. Ensure oxygen delivery through backup oxygen cylinder. You confirm oxygen flow manually. Use portable monitors, right? If the monitors are not working, battery is finished. So communicate with the surgical team and the technical team. And if the backup power is available, wait for the system to restart. Okay. So safety mechanism which were involved in now, which is involved, like we have got internal batteries, which is actually functional for at least 1 hour, right? So manual ventilation, if capability ensures continued patient support, and some machine has manual flow meter control and pressure gauges to confirm the delivery without alerts, right? Okay, so resolution was like manual ventilation and oxygen delivery were maintained via backup cylinder. Like coming on to the last scenario, that is during GA, you notice the patient's airway is steadily increasing. Airway pressure is steadily increasing, and the ventilator alarm triggers for high pressure. Despite normal inspiratory effort, the reservoir bag remains inflated during expiration and the chest rises poor. Capnography shows an abnormal waveform with a rising baseline, indicating incomplete expiration and CO2 retention. What were the clinical signs you saw? Hypercapnia, end-tidal CO2, decreased chest expansion, breath stacking with poor reservoir bag deflation. And if it continued for a longer time, you got hypoxia also. So what did you see? Underlying problem was expiratory unidirectional valve, right? So it was obstructed due to moisture, sticky debris, or mechanical malfunction. So obstructed expiratory valve. Troubleshooting steps: you switched over to manual ventilation. You listened to the breath sounds and checked for the chest movement. Then you inspected the expiratory valve. You removed and examined and then removed the moisture or secretion or mechanical obstruction. You dried and replace the valve. And if the fault persisted, you can switch over to benzoate. Okay. So pre-use check was very important. And all the modern anesthesia machine, they have alarm for sustained high pressure, and it worked in this condition. Okay, in this scenario. So resolution was expiratory valve was found to stuck with consider condensed moisture and debris. It was removed, dried, and reinstalled, right? So after correction, the airway pressures were normalized. So these were my references. Greetings from my college. Thank you.